Okay, the recording's in session. All right. Hello, this is Jackie Druin, and I'd like to welcome everyone to this session. It's being presented by Dr. John Davidson, and I think your last name is pronounced Okwudili. Is that correct?
Yes.
Okay, and he's going to be talking about integrating exercise into HIV rehabilitation in the Nigerian experience. And he's asking that people wait till the end of his presentation for questions. And at that time, when we take questions, we do have a chat line, and I'll show you how that works later on, and then you can type your questions into the chat line. So without further ado, I'm going to turn off my microphone and turn the presentation over to John Davidson. Thank you again very much.
Thank you, Jackie. Good day, everyone. And thank you, Jackie, for this opportunity and for putting me through the WebEx yesterday. I'm John Davidson Okwudili. I'm presenting from Nigeria. I'll be talking on integrating exercise in HIV rehabilitation, the Nigerian experience. It's just to share the experience of what we have in Nigeria, what we have experienced, and trying to make exercise rehabilitation to be in the mainstream of management in HIV rehabilitation. I bring you greeting from my institution, Ekwueme Teaching Hospital. It is a 500-bedded teaching hospital with a full complement of 48 physiotherapists. That is where I work, where I take care of my patients and add value to their quality of life. Nigeria is a country located in the coast of West Africa, bordered in the south by the Gulf of Guinea, Niger on the north, and Cameroon in the southeast, and Chad in the northeast. Nigeria is made up of over 190 million people, and it is estimated by the year 2020, Nigeria will be over 200 million people. Nigeria is located in over 900,000 square kilometers of land. We have over 250 ethnic groups in Nigeria. In Nigeria, according to United Nations Joint Program on AIDS, we have 1.9 million people living with HIV. And adult prevalence of HIV in Nigeria between the age group of 15 to 49 years is 1.5%. We have 130,000 new HIV infections, that is 2018 data, and 53,000 AIDS-related deaths. Also, adults on antiretroviral treatment are 55%, while only about 35% of children infected with HIV are on antiretroviral treatment. But two things are of note here. The 2010 data showed that about 120,000 new HIV infections are recorded in Nigeria, but from 2010 to 2015, you can see that there's a progressive increase from 120,000 new HIV infections to 130 new HIV infections. Whereas from 2010 data, Nigeria recorded 72,000 AIDS-related deaths, but in 2018, we have recorded 53,000 AIDS-related deaths. That means there's a decrease in AIDS-related deaths where there's increase in new infection. Then going to triple 90 targets, it's expected that every person in a country that 90% of persons should know their HIV status, and 90% of those that have known their HIV status should be on treatment. And 90% of those on treatment should be virally suppressed. But in Nigeria, we have only about 67% of people being aware of their HIV status. And among those people that are HIV positive, only 53% are on the treatment. And out of those on treatment, only 80% are virally suppressed. And this is within the age range of 15 to 49. But now in all ages and in all people living with HIV in Nigeria, you now find that there's only 52% of all people living with HIV that are on treatment. Then in all people in all ages, both old, young, and adults, only 42% of all people living with HIV have their viral load suppressed. That means we still have a lot of work to do in Nigeria. Considering the facts, you can see that many people living with HIV in Nigeria are unaware of their HIV status. And Nigeria continues to fall short in providing the recommended number of HIV testings and counseling sites. Then low level of access to treatment remains an issue of people living with HIV in Nigeria. And that's why we are still recording many HIV/AIDS-related deaths. But seeing the fact that the new HIV infection is on increase, even though AIDS-related death is on the decrease. And also, because of advances in treatment and more access to treatment, we'll be having more survivors in the coming years, because Nigeria is putting up policies to make sure that more people access healthcare and access HIV treatment, and that means we'll be having more survivors, more people on treatment, more people having their viral load suppressed, and we know that as long as these survivors continue to live on antiretroviral drug, the effect of the disease and the side effects of the antiretroviral treatment also leads to functional impairment and decreased quality of life among this group of people. And then that shows that there's increased responsibility of the healthcare system to meet up with increased rehabilitation need of this patient. And this rehabilitation need is targeted at reducing disability level and improving optimal functional status so as to improve their quality of life. And one of the ways to improve function is exercise rehabilitation. It is a tool that physiotherapists use to optimize function in this group of patients and also improve their quality of life. And recently, exercise, HIV, and oncology and palliative care has been approved as a specialty area in physiotherapy, and Nigeria key in. But before now, exercise rehabilitation is not a known, is not a field of specialty in Nigeria. But in the advent of this new area of specialization, there are challenges we face in Nigeria to bring exercise rehabilitation in the mainstream of treatment of HIV. Because the policymakers are not aware, Christians are not aware, policymakers are not aware. So we have to enumerate some of these challenges. One of them is that HIV and oncology rehabilitation is relatively a new concept in Nigeria. And HIV and oncology rehabilitation is not contained in entry-level PT curriculum. Therefore, the PTs that are graduating from universities before now, they don't have even the basic knowledge in HIV and oncology rehabilitation, which they will now build upon. And there is inadequate HIV and oncology physiotherapists in the country. And there's also lack of awareness by policymakers on the need for the integration of exercise in HIV rehabilitation. Also, poverty is key because a lot of these people in this country are of low socioeconomic status, and health insurance in Nigeria is not widely, doesn't have wide coverage. Up to 40% of, not up to 50% of Nigerians are covered by national health insurance. And these patients, for them to run in the exercise rehabilitation programs, they have to pay out of pocket. And already some of them are poor, maybe are poor. So out of pocket spending for them can be catastrophic. It can push them down below poverty line. So some of them don't even come. So poverty is also a factor. And limited tertiary health institutions. We don't have enough tertiary health institutions where at least you can have the facilities, the exercise gym, and the trained exercise professionals that can handle this patient. We also have the physician's barrier because the physicians, the tendency is that these people are critically ill, and HIV is a disease of immunocompromise that can compromise the immune system. So the tendency is to tell them, take your drugs, rest, and eat well. So when you come to talk about exercise or to draw exercise program for them, the physicians will think you've come to bother the patient. They don't need to be exerted. So even when you bring evidences from other clients, they still don't have confidence in you. They ask you, can you do it? You have the skill, you have the expertise. Has it been done in this climate in Nigeria where we are? So that shows and exposes that there is also inadequate local evidence to support the exercise rehabilitation in HIV, in people living with HIV. in Nigeria. And that gave need, and that brought about the necessity to engage in a local research in collaboration with physicians in order to build their confidence in what we do, and for them to know that it is real, it is safe, and it has no side effect in this group of people, so far as it's well monitored and supervised by trained exercise professionals. Considering all these challenges, then the Nigerian Society of Physiotherapy swung into action. The first thing they did was to inaugurate the Nigerian Society of Physiotherapy, HIV, Oncology, and Palliative Care Exercise Specialty Group, NSP-HOPE. The acronym is NSP-HOPE. This was inaugurated in 2013, and it was Dr. Nina Chibo that spearheaded it, and the leadership of Nigerian Society of Physiotherapy inaugurated that specialty group to network and build capacity for people who are interested in this area of specialty to practice in it. Then HIV and Oncology and Palliative Care Rehabilitation was now included in entry-level curriculum by the NUC. I think Nena Chibu also contributed to that, and they made sure that at least our PT that are graduating will have the basic knowledge in HIV and Oncology and Palliative Care Rehabilitation, which they will now build upon for postgraduate training and also postgraduate clinical skill acquisition in this area. It has been approved by Nigerian University Commission. Also, there is training of manpower for HIV rehabilitation. You know, the NSP-HOPE started networking, and physiotherapists that are interested in the practice of HIV rehabilitation and oncology now formed to join the IPT-HOPE, engaged in online webinars where they got trained, and only last year, Dr. Anistid visited Nigeria, where she also helped us to build manpower in oncology and geriatric rehabilitation. Over 40 physiotherapists attended. It was a boom for Nigerian physiotherapists. Then we also started engaging policymakers at various levels, both at federal level and at institutional level. And local evidence by collaborative research with physicians. We engage physicians because we say we need to start building up local evidence. We will design researches that we collaborate and lead together with physicians so that they will have confidence about the efficacy of it, the safety of it, and the importance and the benefits of it. So what we are going to do now, we just brought about one of the foremost few works that we did in Nigeria, just about 3 simple works. That's part of the local evidence that have been generated in Nigeria. There are others, but these ones are the earliest ones that we have done. So I will just talk on those 3 works, and we go on to the progress we have made in Nigeria about integrating HIV rehabilitation and HIV treatment. So the first work is where we looked at cardiovascular parameters and body composition parameters and quality of life of people living with human immune virus using a 6-week aerobic exercise. I was the principal investigator in this work, and it has been published in Journal of Exercise Rehabilitation. You know, to design this work, we went to literature where we now got some facts that the effect of HIV disease progression and effect of the therapy, which is hard, can lead to discrete functional status, which will also reduce their quality of life. And because of increased number of people living with HIV, there's a demand on the healthcare system to attend to the increased rehabilitation need of this group of people. And this rehabilitation intervention and rehabilitation need is targeted at reducing the disability level and increasing the functional status, which at the end of it, and on the long run, will increase their quality of life. And also, people living with HIV have been shown to have decreased aerobic capacity, that's VO2 max, and decreased physical work performance, according to a case they saw in 2000. And also, around 25% of people living with HIV have hypertension because of sedentary lifestyle and increased risk of cardiovascular risk. And also that heart also leads to some morphological changes and psychological adverse effects. And we said we would look at these things, how exercise can mitigate or ameliorate some of these side effects, because it becomes necessary to develop protocols in Nigeria or treatment models that will mitigate these side effects, which have the aim of enhancing quality of life in HIV population. So the study was a pre- and post-control randomized design. The consultant hematologist was part of the study. She was the contact person that recruited the patient. 7 to 9 subjects were identified, but 5 refused after the briefing. 10 were not eligible based on inclusion and exclusion criteria. 60 subjects were randomized in 30 into the control group and 30 into the exercise group. 3 dropped out before the end of the study from the control group, and 5 dropped out of the study from the exercise group. At the end of the day, we had 27 control group and 35 exercise group that completed the study. The control group only received nutritional counseling twice in a week, while the exercise group received the aerobic exercise training alongside nutritional counseling 2 times in a week. We administered moderate intensity aerobic exercise for a maximum of 45 minutes 3 times per week. We used the initial brisk walking at 0 grade on a treadmill for 4 minutes. This is just a kind of warm-up to raise the heart rate within 40 to 50 of predicted age maximum, which is 220 minus age, according to the American College of Sports Medicine, to adapt the heart, because you can't just put someone that hasn't been exercising into moderate intensity exercise like that. It's exercise training. Then this was followed by a second 4-minute stage, 10 speed, but treadmill was raised a 5% grade. Then the speed was also increased as training progresses on a target heart rate of 60 to 75% of predicted heart maximum was reached. This is the training range that we targeted. So exercise training, exercise was monitored using both perceived rate of exertion scale. Also, the heart rate was also taken every 3 minutes as an additional monitor. And VO2 mass was calculated with the formula you are seeing according to American College of Sports Medicine. Then all measurements were also taken at baseline and at peak. You remember cardiovascular measurements, like diastolic blood pressure, systolic blood pressure, the heart rate, and the body composition. We measured the BMI, the waist circumference, the visceral fat, and the body fat percentage and muscle mass. All these we are taking at baseline and at 6 weeks. Then the results showed that there's improvement in cardiovascular parameters in the case of systolic blood pressure, diastolic blood pressure in the control group, but it did not attain significance. But improvement in the experimental group in systolic blood pressure, diastolic blood pressure, and heart rate was significant. There was decrease in them. Therefore, these patients in the experimental group, they have better cardiorespiratory, cardiovascular fitness at the end of the study. And this group of patients also decrease the physical endurance, and having better control of their cardiovascular fitness can help them in function, and they reduce the risk of hypertension and risk of other comorbidities. Then significant improvement in cardiovascular parameter when you compare the experimental and the control group. The difference was also very significant. And cardiorespiratory fitness, VO2 mass, improved significantly in the experimental group compared to the control group. Results also show significant improvement, decrease in the body composition parameters of waist circumference, BMI, and percentage body fat. And there's increased muscle mass in the experimental group. It was very, very significant. Body composition parameters also improved significantly when you compare the experimental group and the control group. And there are also significant improvements in the scores in all the measures quality of life domains, both in the control group and in the experimental group. That means that the control group that received nutritional counseling was able to achieve significant improvement in all the domains of quality of life. Also, the experimental group also had significant improvement in all the domains of quality of life. Then adherence. We also noticed that there's high completion rate of 80% we recorded in this study, and that's reported by similar exercise intervention trials. We have 3 studies that we conducted that had 70% completion rate, 77% completion rate, and 78% completion rate, respectively. But we noticed that within the first 2 weeks of the exercise, there are some reports that the subjects gave to us. They said that they had reduced muscle and joint pain, and the endurance increased. And we thought that this immediate improvement that they got within the first 2 weeks is responsible for them adhering to the exercise, and we recording 50% completion rate. Within the first 2 weeks, some of these are the testimonies or the feedback some of the patients gave to us. They said, one of them said, I can now walk from the hospital gate to the clinic, before they have to carry her in the car to the clinic gate. She now entered. But now she can now walk from the clinic, from the hospital gate to the clinic. The other one said, the pain in my body has reduced and I can sleep very well at night, even though we didn't assess sleep disturbance in the study. But these subjects gave us feedback on that. And some other person said, I find it difficult to cook due to fatigue, but now I can complete my cooking without getting tired, even though we didn't assess fatigue. But we can see that what we are doing also improved energy. I can now climb stairs without gasping for breath. I can now wash my clothes without having frequent breaks. So these are parts of the feedback that we got, and it was encouraging. We put in our best, and the subjects kept coming. They adhered to the exercise program. So we now conclude that a 6-week aerobic exercise intervention coupled with nutritional guidance was able to significantly improve cardiovascular fitness, body composition, and quality of life, while nutritional counseling alone brought about an improvement only in the quality of life. Then one of the work again that I want to briefly present is the work done in another center where by Nina Chibo. Also, a physical physician was part of this study, and that physician was also, at that time, the chairman medical advisory committee. So therapy intervention as a complementary treatment for people living with HIV/AIDS, published in HIV and AIDS Research and Palliative Care, Luke Press, was a case report of 43-year-old female diagnosed of HIV. The patient has been on 8-year heart regimen. She had a well-managed HIV. There are lack of comorbidities, and the patient was well motivated. This patient declared interest after a health talk that Nina always do in the HIV clinic. The patient volunteered to probe more into the benefit of exercise, and she volunteered to be part of the study, and it was a case study. The primary complaint on evaluation were pain, weakness, and decreased endurance. On evaluation, the 10 repetitive maximum was used at rest strength. The measurement of high, upper arm, and waist circumference was done using standardized protocol. CD4 count was assessed using laboratory procedure by the laboratory scientist. And peak expiratory flow rate was assessed using spirometer. Then on evaluation, upper and lower pain, there's upper and lower back pain that recorded worst pain on a visual analog scale. And the mid trapezius, erector spinal, and latissimus dorsi models all showed increased tenderness to palpation. And the patient recorded it at worst pain. And there was also shortness of breath on mild exertion, and prometic changes like increased belly fat, decreased musculature of the extremity, occasional loss of balance with exertion, fatigue, and low self-esteem. And intervention, as I said earlier, it was 12-week physiotherapy regimen consisting of aerobic and resistive exercise components, 3 times weekly for 30 minutes on non-consecutive days. Soft tissue mobilization was done to the upper and lower back, mid trapezius, erector spinae, and latissimus dorsi. Then STM for initial 2 weeks, after which the patient had no further complaint of pain. STM was used, soft tissue mobilization, to address the pain on the upper and lower back. The mid trapezius was tender, erector spinae, and latissimus dorsi. But it worked like magic that after 2 weeks, there was no complaint of pain at upper and lower back. Aerobic exercise was performed at 50 to 60% of heart rate reserve, 30 to 40 minutes of walking on the treadmill at the patient's own pace. Heart rate was monitored during the exercise session. Oxygen saturation was measured at regular intervals using a handheld pulse oximeter as an additional monitor. Then this is a flow chart of the progression in the exercise from week 1 to week 2. The aerobic exercise percentage heart rate reserve, there was a progressive increase from 50% to 60% from week 1 to week 12. And also, the repetitive maximum was assessed and reassessed as the exercise progresses. And the percentage of repetitive maximum set that patient does also increased. The last column from 60 to 70 to 80, because the target was 60 to 80% of heart rate reserve or the resistance exercise, but for aerobic, 50 to 60 heart rate reserve. And the results showed a complete elimination of pain and shortness of breath on exertion, and there's reduction in resting heart rate and waist circumference. There's increase in peak respiratory flow rate, and there's increase in maximum heart rate. Then there's increase in upper arm, forearm, and thigh circumference. Also, muscle strength also increased, and there's also increase in muscle endurance. Then the CD4 cell count also has slight increase. Then there's also improvement in all the domains of the quality of life. Well, this is a bar chart that shows the percentage changes in the quality of life domains. The least percentage change that was recorded was 25%, and that was in social functioning and role functioning. And the highest was in general health, 90%. You can see the differences. There was percentage changes, good percentage changes. So there is improvement in the quality of life of the 43-year-old female patient. Then the case study showed the positive effect of a therapy intervention in a 43-year-old woman living with HIV. Then the last work that I will present tonight is a simple one, but because of our locality and our climate is still very important here. We looked at the relationship between self-reported physical activity level, hematological indices, and health-related quality of life in people living with human immune deficiency virus. Published in HIV and AIDS Review, International Journal of HIV-related Problems. It says cross-sectional design. 80 participants were conveniently recruited based on availability and willingness. And the IPAC, the International Physical Activity Questionnaire, short form, was used to assess the PA level of the participants. And the rank that this health-related quality of life questionnaire was administered to each patient to ascertain their physical activity level and health-related quality of life. The participants were divided into 3 groups following outline. Those that are into physical activity, so the metabolic equivalent activity level, the MET value is less than 600. While the moderate intensity physical activity level, the MET value is between 600 and 3,000. While in high intensity physical activity level, the MET value is of 3,000 and above. But in the IPAC questionnaire guideline, it is stated it's simple how to drive and get at all this. And the rank at this questionnaire was used to assess the health-related quality of life, the 8 domains: physical functioning, role limitation, caused by physical health problems, role limitation, caused by emotional problems, social functioning, emotional well-being, pain, general health perception, perceived health. During the last week, the results show that there's a trend of increase in hemoglobin concentration and white blood cell count following increased physical activity, but it wasn't significant. Then there's increased scores in the subdomains of health-related quality of life following increased physical activity level. That means as the patient increase from the low intensity to vigorous to moderate to vigorous intensity, at the level of physical activity increases, the health-related quality of life score increases, showing improvement and better control of their quality of life. There was also a significant correlation between physical activity level and subdomain of social functioning and pain. And the significant difference, we also saw a significant difference in the mean scores of the subdomain of social functioning and role limitation due to physical health across the physical activity level. But that means that participants in the moderate and vigorous intensity level of physical activity category showed better scores in the two subdomains as compared with participants in the category of low intensity physical activity level. So we conclude that improving participation in physical activity may result in a consequent positive effect on some hematological parameters and a significant positive change in health-related quality of life of this population. But why we decided to embark on this work is considering the fact that Nigeria is still a developing country, and considering the fact that most of our patients that are HIV positive reside in the rural location, there's difficult for them, there's difficulty in them accessing tertiary health facilities where they have facilities for exercise intervention, or where they have trained exercise professionals to take care of them. So, simple advice on exercise and encouragement of the patient to be more physically active and sportive. So we also want to carry the physicians along, that even in centers where they don't have physical therapists that can do this, let the physicians at least know the importance of physical activity. Let themselves in the clinic, let them advise patients to be physically active. It will improve their quality of life. It will improve their quality of life, and it will also have some positive influence on their hematological indices. So in Nigeria, there are a lot of progress that we have made. HIV and oncology rehabilitation is no more a new concept in Nigeria. IPT-HOPE has been inaugurated. There are capacity building workshops that is ongoing, that has been ongoing even with the WCPT IPT-HOPE. And HIV and oncology rehabilitation and palliative care is now contained in entry-level PT curriculum. So our graduating PTs will have basic knowledge on HIV and oncology rehabilitation. And there's a growing number of HIV and oncology PTs. Only last year, Dr. Ninstead Ann came to Nigeria, where she also organized capacity building workshop for us. A lot of PTs participated, and they became interested. And physicians are now more aware of PT roles since there are collaborations with them. There are other ones apart this one we presented. Many other people in Nigeria are doing great in this area, collaborating with physicians. There are more centers are adopting exercise as routine in HIV rehabilitation. And more local evidences are emerging on the current trend on exercise intervention in HIV rehabilitation. More people are coming in, more people are doing work in different areas of HIV in Nigeria, and they are PTs. We now have the presence of HIV oncology and palliative care physiotherapy in at least one tertiary center in all the geopolitical zones. Physicians are more aware of exercise intervention in HIV rehabilitation, and more PTs are also appointed into small boards in various centers. Because HIV rehabilitation goes hand in hand with oncology rehabilitation and palliative care. So future development, we look forward to when they will have the Faculty of Oncology and Palliative Care created in Postgraduate Physiotherapy College, and inclusion of exercise rehabilitation as a national guideline in HIV management in Nigeria. What we have now is institutional-based policies where they have adopted exercise rehabilitation in HIV management. We're looking for when we have a national policy document, that it will be a national guideline, which everybody will be in. Thank you. These are my references.
Thank you very much, John. This is Jackie Druin. I just wanted to open up the audience to questioning. Ask that you ask the questions on the chat line. So if you scroll to the top of your computer, you'll see a drop-down menu that comes down that allows you to chat. And if you could type your questions into John there, then he can answer them. So if anyone has any questions for John, while we're waiting for questions, I just wanted to make the comment that I'm so impressed with what you've accomplished in your country, and we're seeing some of the same issues here in the USA. That first off, we have to educate the physicians to what we do. If we can't educate the physicians to what we do and have them appreciate rehabilitation and exercise, they don't even know that sometimes we're out here and can help with what's going on. So that's a really important factor. And I think Newstead was, she loved coming out there and meeting with people and doing case studies and working with some of the physicians to get them on board with what happens and the importance of rehab. The other thing is that your idea about educating patients about exercise, that's important too, because sometimes the patients can actually drive the opportunity and ask physicians to be referred to a healthcare professional or ask to talk to a physical therapist about exercise. So if patients don't know that that's out there or don't know the benefits of what they can have, then we're not going to be able to move forward with progress with patients with HIV/AIDS. And your publications are just remarkable. They're so important for us to have evidence that people can go to, because especially physicians are the ones that are going to want to go and see this. So I do see that there's a comment from Anne to all the panelists. How can we motivate people to move? Would you like to respond, John? How do we motivate people to move?
I haven't seen any questions. I haven't seen any questions.
The question was, how can we motivate people to move? And that's from Anne. I'm assuming this is Anne Newstead.
Hello? Hello?
John, can you hear me?
You said what?
How can we motivate people to move, to be active? How can we motivate people to be active?
Okay, how can we motivate people to be active?
Yes.
Okay, in this context, what we did in this context of HIV rehabilitation, that is the importance of the last work that I shared that we did. We always find a slot in the HIV clinic so that we can have health talk to them, where we are focusing on the exercise and the importance of exercise and its benefits. And most times we now find out that these people, they don't even know, even people that are normal, that are not HIV positive, normal individuals, a lot of them don't even know the importance and the benefits of exercise. But when you now come and list and enumerate in deep the negative effects of not being active, inactivity, that is when they become interested. So we try as much as possible to expose the negative effect of not being active, as the effect of inactivity, and we now expose the effects of physical activity to them. And most of the time, they show interest to engage in physical activity and go along with us. That is what we do in this context. And once they start seeing the effect in one way or the other, and it's another motivation for them.
Okay, thank you for your. Does anyone else have any questions that they'd like to type in the chat line? While we're waiting for your questions, I have here's one. What about people who cannot get to a clinic? How do you work with them to account?
Okay, people that cannot get to the clinic, we do advocacy. We do advocacy. So that advocacy is in so many ways, like the one we did recently was in collaboration with Breast Imaging Society of Nigeria in Enugu chapter. We did it in the capital, and we went to some selected nearby rural areas to give health talk, but that was centered on breast cancer and the importance of physical activity. And it was amazing, the turnout and how people appreciated it. But one of the goals, again, of NSP-HOPE, now we have known that exercise is efficacious. It's an efficacious intervention in ameliorating some of the side effects of HIV disease progression and its treatment, especially the physical side effects. Then, having known that these interventions are efficacious, the problem is coverage. We don't have enough number of physiotherapists. Even people, some of them, as I said, poor people, they cannot even access the clinic. They don't have the money and they're in remote location. So we are planning on implementation research, implementation study. And one of it that we want to also find out other exercise intervention that does not require treadmill, no equipment that will require you coming to institutions or we carrying the equipment there. That is even one of the work that I'm doing now in my PhD, using circuit exercise to adapt it to different stages of HIV. Once we can prove that it's efficacious, we now do implementation research, how these things can be done even in rural community without even a specialized trained exercise professional to administer and start monitoring the heart rate and on the treadmill with all those gadgets. Simple exercise. We are bringing into simple exercises that will now carry out implementation research, implementation studies, so that it can have wide coverage. That is one of our goals now. And I know that in no distant time, in the nearest future, by God's grace, we will achieve that.
Thank you, John. Question, and it's from Alumidi Dada. I hope I'm saying your name correctly. And they want to know, at what stage in HIV do you intervene? Do you do exercise? At what stage, what level of HIV do you start exercise? So what level of illness are they at?
Exercise can be started at any stage, just like in cancer. People think, well, you get to stage 4 or stage 3, you cannot exercise because of fatigue. Yes, we know that fatigue, for example, in cancer, is a limiting factor to exercise. But then you individualize the exercise and do it according to the patient's fatigue and energy level. At any stage, they can do exercise. I've told you of one of the work I did that I presented. This lady cannot walk from hospital gate to the clinic. She had to be driven to the clinic. She will now enter. The first day she entered treadmill, she did not stay up to a minute. And after, she did not stay, she could not complete the 4 minutes warm up. The second time, she could not complete the 4 minutes warm up. But by at the end of the 6th week, she was able to attain 45 minutes. It's extra training. You adapt it to the patient. Depending, considering from your evaluation, considering the challenges, the energy level, and what the patient can do at patient pace. At any level, the patient can exercise. So far as other contraindications are out. Because before we started, we also use American Heart Association and American College of Sports Medicine pre-participation screening, where you screen for cardiovascular risk, history of cardiovascular events, and a lot of things. And there are other things, like when they draw blood, you know, in the next 24 hours and not supposed to exercise. And there are other contraindications that have been listed according to American College of Sports Medicine. So far as those things are not there, you can exercise at any level, at any stage.
Thank you, John. There is a question about how do we take care of this, how do we take this exercise rehabilitation to rural areas?
Hello? I didn't get you.
One of the chat messages is, how do we take this specialized care to rural areas, so areas that are outside the cities, areas with limited access to the cities?
That is, I think I've addressed it partly. That the specialized services that we are talking of now, you see, we are encumbered. We cannot carry our equipment from the tertiary hospitals that the government only provided. We carry it to the rural area. It's only when government is committed. If the government can provide these facilities, specialized these facilities that are needed for this specialized exercise intervention to the rural areas, health centers, all those places, that is the only time we can do the kind of thing we do in the tertiary institution at the rural areas. If not, we cannot do it. That is why we are even agitating for physiotherapy to be included in the primary health care. At least the physiotherapy in the primary health care, we have basic knowledge of HIV rehabilitation and oncology rehabilitation. This can do something before it gets to the level of referring to the tertiary health level. But what we still do is that we continue to do advocacy. We go to rural area, we advocate for exercise, physical activity participation. We continue to do it. And when we go there, we structure simple exercises that we give to these people, which even we only believe that they can continue it. It is not rigorous. One that we know that will not lead to fatality. So far as those patients or those individuals are stable, we continue to do it. And that is one of our mandates. And we'll continue to do it until things get better.
Thank you, John. Nina has a question she's going to talk to verbally. Nina?
Okay, yeah. Hi, Jackie. Hi, everybody.
Miss you.
Yeah. Davidson, I'm so excited. Thank you for being so vocal. Yeah, just like you said, in Nigeria, I think what we need now is help in getting across to the government. If anybody has any advice on how to get government to be involved in what we're doing, we are open to that. I just want to thank him for being open with what we are doing, the stage where our challenges in Nigeria. And also thank him on behalf of IPT-HOPE. And in the next couple of days, we'll be sending out a scholar award to you, which you can display anywhere, use it progressively. You have done a good job. Thank you.
Thank you.
Yes, that's wonderful. Thank you, Nina. There's another question from Emily, but before I put that question out, I wanted to respond to Nina, where she's talking about how do we get involved in, or get the government involved. And I had a professor from South Korea who stayed with me last year, and he studied oncology rehab. And in his country, in South Korea, the physiatrists, which are rehabilitation medicine doctors, they are totally in charge of what the PTs can do or the physiotherapists can do. And so one of his comments was that even though he's a PhD professor and a dean at his school, he thinks the best way for him to get involved and improve cancer care and HIV care in his country is to become a member of the government. So if he can run for one of the positions within the government, he can influence healthcare policy by being part of that. So that's a suggestion for you that I learned from South Korea, Nina. I don't know if that would work in your country, because most of us who become PTs want to work with patients.
Yeah. Thank you, Jackie.
You're welcome. All right, Emily and Ekwueme would like to know, how do we take this specialized care, to rural areas? We answered that. And then he had a second part. What role does exercise play in improving immunity among HIV? So John, the question for you is, does exercise improve immunity in HIV patients?
Studies have shown that exercise so far is not vigorous among HIV individuals, does not run down the immunity. There are researches that say that the CD4 count remains unchanged. And there are studies that show that CD4 counts also increase. One of the work that Nina did that I presented, CD4 counts increase. And also in the last work that I presented, we saw that increased physical activity level led to increased white blood cell counts, which is also implicated in the fighting of pathogens that enter the body. Exercise improves immunity in HIV. Exercise improves immunity in normal human beings. Exercise improves immunity in cancer patients. It is a plus, plus, plus. So far that it did not over-exercise and it is not vigorous. Within the moderate intensity level, it improves immunity. In fact, it has led exercise to be one of public health concerns, to be included in public health policies in some clients, because in sports persons, exercise, they used to improve immunity, but when they over-exercise, they come down with upper respiratory tract infections, and it's seasonal in sporting activities. It's even a public health, exercise becoming a public health policy in many clients. It improves immunity. No arguments about that, no controversy.
Okay. Is there any other questions? The only comment I do see on the chat line is that Anne is saying, thank you, Davidson, for such great work, such a great presentation. So thank you for your comment, Anne. I do have one additional comment and question. In my studies with breast cancer, we did similar exercise to what you did, where we did a treadmill test and then we gave them an exercise. And what we found was, in terms of adherence, we did not lose anybody that was in the exercise group. And yet, when I go through articles on breast cancer, just like what you found with HIV, that about 70 to 77% of the patients who are exercising drop out. And my thoughts are on that is, first off, they may not be given enough education about the safety of exercise for them and the importance of the benefits. And then the other thing, I'm concerned that some of the studies, if they're not carefully testing them and determining what their exercise intensities are based on the exercise test, then some of the prescriptions they're being given, just with predictive equations, may be too hard for them, and that's why so many of them are dropping out. Would you like to comment on that with the HIV patients, that you had such good adherence? Do you think it was because of the good education and the good exercise tests, or do you think there were other factors?
Thank you.
Do you think that there were reasons why you had such good adherence to your exercise?
Hello, I didn't get to.
Oh, I'm sorry. Do you think there were reasons that you had such good exercise with the HIV population?
Okay, I think there's reasons why.
Adherence, why so many people stayed with the program and performed the program, that you did not have too much dropout?
Okay. No, the only thing that I thought, I think that is the reason why people stay. You see, exercise is very, very beneficial. Like the work I did, the only thing I say, anytime I engage people in exercise, HIV patients, they come up with testimonies, especially pain, body pain, muscular pain. There's a reduction in pain. And apart from reduction in pain, you also adopt that there's this motivational interview that I do with the patient. By the time I do motivational interview, I'm interviewing them and also do some motivational inquiries and talking to them. You see them opening up. Sometimes from evaluation, they move away from the disease component, and you start to know about other parts of the suffering they are going through. So you now do a holistic assessment, trying to even find solutions outside the clinic work, like in social work, how to get some money. You can help the person, but the person become very committed. The person become relaxed, and he wants to always come. Because anytime he's coming, looking forward that a part of suffering is going through will be alleviated or taken off him. And we keep doing that because we know that these people are in suffering, majority of them, and they need help. We continue to give in our best. That is the only thing we do, and think it's working. It's working to some extent.
That's great. Final questions for John?
Hi, John. Hi, Jackie.
Hi.
Familiar. Thank you, John, for the presentation. It's been a very wonderful time having you here. I enjoyed every bit of it. For everything we've been doing, you really caught it. You captured it very well, and you presented it aptly. Thank you so much. And Jackie, thanks for the opportunity to interact with everyone in here. Thank you.
My pleasure. Thank you.
Thank you. Thank you.
Any other comments or thoughts? Okay, well, John, is it possible for people to send you an email if you need to, if they have questions that come up after the presentation?
Yeah, sure.
Do you have? Could you type your email address if they have questions for you?
Yeah.
Maybe on the bottom of the last slide. Or, on the 40th. Oh, okay, yeah. If you could type your email someplace here, it would be great.
I see it.
Yes.
No. Okay.
Or maybe put it on a separate slide, Davidson.
Okay, all right.
Just put it on a slide, on the last slide.
Okay, let me.
That's better.
Thank you.
Yeah, that's better. Thank you. That's better.
Thank you very much.
Bye. Sign out.
Okay, so this is recorded, so if any of you came late, you can check the recording. We should have it on the WCTT IPT-HOPE website probably by later this afternoon, and then it'll be up there if people missed it and you want some of your colleagues to be able to access it and see it. So, John, thank you so much for your presentation. I learned so much about what goes on in your country, and I think the education that you're doing based on the publications that you have are going to be a wonderful touchstone for people around the world to be able to look at and see and then learn from and model some of their behaviors. So thank you again for your presentation.
Thank you.
Yes, it was wonderful. And if there are no further questions, I will be signing off here. So have a great afternoon and end of the day here, everyone.
Yeah. Bye-bye, everybody.
Bye-bye.
Goodbye. It was good to see everybody.
Bye. Bye.
Bye-bye.
You see, well done.
Okay.
That was a good one.
Dr. Comfort, how are you? Thank you for coming
Good
on.
job, Gina. Emilia Olumide, thanks for showing up. It was great.
Yeah, thank you.
Thank you all. I'm happy with this. We are moving forward. That's a good one. Well done.
Thank you.
Bravo.
Thank you.
Yeah, bye.
Bye-bye.
Bye.
Bye.
Dada. I agree too much in Dada.
Bye. Well done. Great work. Great work you did. Very good.
Thank you again, John.
Okay, thank you. Thank you.
Bye-bye. I'm sure we'll be in touch.